Uh, all right. Good afternoon. A very good afternoon to all my audience out there. Okay. It's my pleasure and honor to be in the webinars again. In fact, this is my second webinar that I'm doing a surgery topic. Of course, I'm from surgery department. I'm a surgeon. I'm Mr. K. All right. Today, I'll be sharing with you all a topic which is quite almost similar the first webinar that I had is about spleen again, right? I remember I talked about splenic abscess, yeah? So this time I'm going to talk about spleen, but it's another issue. I wouldn't say it's a big issue, but quite it's quite different and abnormal. I guess nobody will know about this spleen. So uh, the topic is floating spleen. All right. I saw this case a few years back. Uh, I thought I want to share with you all. Maybe someone already have been seeing a case like this, but I think it's the first time to me. All right. Uh, Spleen, it's the biggest immunology organ in the human body, as we learned in anatomy last time in our MBS. It's located in the left upper quadrant of the abdomen, and its position is stabilized by various suspensory ligaments. All right, and floating spleen, or we call it wandering spleen, or whatever spleen. It's not at its normal anatomy position, but it's a very unusual clinical entity. Uh, this is because of its the ligament, the suspensory ligament. It's really prolonged, and the spleen is can wandering around in your abdominal cavity. Now it can present as an asymptomatic palpable mass. It depends on how big the size. I remember when I first learned my spleen, 1, 3, 5, 7, 9, 11. All right, so 1, you know, 3, 5, it's at the 9 to 11 ribs at the back. So it depends on the size. If the size is big, maybe you can feel a little bit maybe discomfort to certain patients. But if it's big, maybe it will constantly cause abdominal discomfort. Uh, if the complication sets in, there will be a acute emergency, right? Because of these unique features, it has been a diagnostic challenge for all the clinicians out there, especially me. Now, here I would like to share a case again. It's of a floating spleen in a 17-year-old female patient who came in diagnosed as acute abdomen. Now, beginning, I think it's based on individual capabilities and experience to recognize such condition. So it is very important if you know and you can diagnose as soon as possible because its management is different at various stages. Now, because here I would like to share this experience, and of course, maybe you can put one of these as a differential diagnosis in your patient, maybe in future when you have a similar condition happen to your patient. Now, this patient, it's a 17-year-old female patient. She came to A&E with a complaint of abdominal pain for 5 days. Of course, as usual, we clerk the patient A&E, the MO clerk the patient, the pain according to her, it's a sudden, yeah, it's a sudden, she had never had this before, and it's a sudden, and the pain is like a very, it's not very sharp, it's quite, it's distributed all over, beginning is in the center, then later distributed all over the body, the abdomen. According to her, the score is around 8 over 10. So sometimes when you eat and when she eats and when she moves, when she walks, the pain will be even more. Sometimes also associated with vomitings, but it's just clear vomiters and no blood, no hematemesis, no, it just digested food. Now her bowels, according to her, were opening regularly. Well, there's no like auto bowel habits, and there's no blood in the stool, and of course there's no fever, and at that time there's no recent trauma involved. when we asked her about the family history, nothing special to be mentioned about. It's just normal, and of course, her menstrual history also normal. Now, when we examined her, she appeared to be very in discomfort, but no fever, no aparaxia, sorry, but had a tachycardia of 92 beats per minute, with otherwise normal cardio, CVS, and respiratory function. Her abdomen, when we examine, we noticed that we revealed a tender, a big mass, measuring 10 cm times 6, all right, with a well-defined margin, smooth surface, or maybe a little bit smooth at the left side, and it's a bit, what do you call that, bossulated surface, and firm in the low part of the abdomen, right? So of course, go on with a laboratory investigation, and then the hemoglobin, the white cells, the platelets count were normal, right? So then a serial investigation, we sent for ultrasound. Patient was in the wards. We sent for ultrasound, and the radiologist proceed to a CT scan because she noticed that a CT scan will maybe will tell you more, will discover more important features or information to your diagnosis. So she was sent to for emergency CT scan, and later once the diagnosis was made, the patient was planned for emergency exploratory laboratory. Okay, this is a CT scan. I just want to show, you see, when you have a normal CT scan abdomen cross sections, the liver is here, and surprisingly, the spleen is not there. It's not at the normal positions. So where were the spleen? So we notice that the spleen, that's a big mass there. Look, it's just below the abdomen, below the umbilicus abdomen, sorry, and that is what do you call that? Okay, you can say that it's a round or kidney shape, like in this cut film, and it's quite homogeneous, and there's some accumulation of fluids, and the bowels looks normal to me. So then we go on to the laboratory. We notice that that is a mass was identified as a spleen. Why? Because we can see the mass, of course, the kidney shape, or right, more or less the bean shape or kidney shape, and we can see there's a notch there, and we couldn't find any other spleen mass from its normal position. That was empty. All right. And this mass, there's no other ligamentous support seen. All right, and we found that the spleen was found that to be infected. The colors become a bit blackish, purplish and blackish, due to the twisting of its splenic particles. This is we managed to take a photo, and we can see that here a little bit of accumulation of fluids, and the color is this color when we open. So minimal hemoserous fluid was found within the small loops, bowel loops, right? So after consider all of the findings that we had, so we did a total splenectomy. All right, the patient recovered well post-operatively, and she was discharged from the ward after 1 week. And of course, patient was advised for the vaccination against all the pneumococcal disease, Haemophilus, and influenza in the follow-ups. Now, okay, now I'll share a little bit of discussion here. Again, floating spleen, it's a very rare condition in which the spleen migrates from its usual anatomy position, commonly to the lower abdomen and pelvis. Why I say rare? Because the incidence is it's less than 0.2% in the world. All right, and usually with a literature say that reported between the ages of 20 to 30 with a sex ratio of 7:1, yeah, females to male. If a person is born with this condition, it is referred as to be a congenital wandering spleen. But we have an acquired wandering spleen may occur during the adulthood, maybe because due to the injuries or other underlying conditions that makes the ligament support become weaker that hold the spleen. So when it depends on the situation, when because some spleen can lie at the side, some spleen will come up from the normal position and go towards the lower abdomen. You know, so floating spleen is characterized by the excessive mobility and migration, and from its normal position in the left hypochondrial due to the lack of fixation and unduly long splenic particles. Right, as we all know that usually spleen will support is normally fixed in that position by the gastrosplenic and lienorenal ligaments. So congenitally, a floating spleen, it's the results of the failure of the development of this ligament, which results that it has a very, you can say it's long splenic mesentery. I'm showing you this is a normal spleen now. Okay, so normal spleen should be this color. Of course, this is really a large size. Okay, some congenital anomalies can get involved associated with this disease, like prone belly syndrome, like in a child where they have entry abdominal defect, and prone belly syndrome. All this, of course, they are poly. That means they might involve their urogenital, so they might have this spleen problems, or even hypermobile colon. These are very very rare. Okay, so that's why we call it a rare disease in this fluid spleen. Now, the acquired anomalies usually occurs in an active reproductive woman because they suggest, literature will reveal that the pregnancy may contribute to the ligamentous lengthening, to the laxity of the abdominal wall, and of course, the hormonal changes during the pregnancy. And both congenital and acquired condition results all this in a long pedicle. This is why we are worried, the complications, which is predisposed to a torsion. All right. So, like what happened to our patient, there's a torsion in the splenic pedicles that leads to the infarct, and the pain is sudden. So that's why cases like this we need to identify and maybe we do a splenoplasty to avoid this complication. Right? The splenic vessels close within the pedicle, therefore, in a torsion of the pedicles results in partial or even a complete splenic infarct. So infarct of the spleen. So torsion of the wandering spleen is diagnosed in about 0.5% patients who require splenectomy. Right? We are trying to say that we try to salvage the spleen as possible because it's the biggest immunologic organ. We cannot afford to lose it. Just give me 1 minute. Okay, so splenic torsion may be acute and chronic. We talk about later. So acute torsion, like what happened to my patient, may mimic peritonitis, like appendicitis, twisted ovaries, or bowel obstruction, which means they can just come in with acute abdomen. So usually, of course, appendicitis will be the first diagnosis, but then we shouldn't neglect or we shouldn't forget about this case, this disease, this type of diagnosis. But chronic torsion may present uh, as an abdominal mass, which may be located in any quadrants. So, of course, when it comes to investigation, besides your short clinical diagnosis, or we usually send for ultrasound or even a CT scan. Absence of the spleen from its normal position will help us, and therefore will make it a better and faster decision. Even Doppler ultrasound of the spleen vessels can be used to evaluate the flow. Okay? So a CT scan remains the investigation of choice, and we can demonstrate the organ circulation and viability of the splenic parenchyma. I'm showing you this CT scan. You can see the spleen is not at its normal position and bowel is occupying it. And you can see the splenic particles, and you can even see the spleen going down to the pelvic cavity. Okay, this is another type of what we call a floating spleen, where it's very, very big, and somehow you can cause adhesion here and there. It's at the lower part of the abdomen. This is another twisted. All right, so it depends on the situation when they come in. Now today, of course, you cannot do anything, but surgery is the gold standard treatment of this. Either you can do it conventional or you can do it laparoscopic. And also splenectomy is indicated for the infarcted spleen, but sometimes because all these spleen, when they float around, they tend to be a bigger than normal size, and even a huge splenomegaly can precluding the splenoplexy. So very difficult. The spleen is quite big. All right. And for all other cases, splenoplexy is the treatment. If we notice that the spleen is salvageable, we try to do a splenoplexy. Something like testes, we do a ketoplexy. We try to save the spleen. For children with congenital wandering spleen who are experiencing episodes of torsion and acute pain, the treatment of choice may be surgery that anchor the spleen back in the proper position in the left abdomen if the spleen is salvageable. All right, we couldn't afford to throw away the spleen. Splenic preservation is highly recommended for young patients. As we all know, those under 1 year of age up to those in the 30s who are at a particular risk for overwhelming post-splenectomy sepsis. Now, people who have had a splenectomy are at a higher lifetime risk for serious infections and than in the general populations. Now, immunizations to boost immunity against Haemophilus influenza B, Streptococcus pneumoniae, Caesarean meningitis, and other contagious diseases are usually administered before the splenectomy is performed. Now, okay, we come to the last slide. So I would like to conclude, yeah. Floating spleen, again, is quite rare in this world. It can be asymptomatic and it can be very symptomatic, causing acute abdominal symptoms. We have to go in once we diagnose as soon as possible because surgery is still the gold standard, and we try to salvage as much as possible. And the surgical approach can be from a splenopexy to a more common splenectomy. Either you do it openly or laparoscopically. Right? Okay. Right. That is all about my talk today. Thank you. That's my references. Thank you.
Thank you, Mr. Pei.
Yeah.
Can you just summarize for us, because we have difficulty seeing your slides. Can you summarize for
Okay.
us the management of floating spleen?
Yes. Yeah. The management of the splenectomy, floating spleen, as I say, we cases have to be identified as soon as possible. And patients come into like even the mild pain with the mass in the abdomen. Once we diagnose, we have to do like a splenoplexy in order, because when they go into the complications like twisting, all this, it can be get infected, and therefore we have to do a splenoplexy, especially for the young and for the adults. Hello.
Thank you. Uh,
Yeah.
for the benefit of the viewers, let me give you a background of Mr. Pei. He received his MBBS in 1995 from Manipal Advanced uh, Academy of Higher Education, and trained for his master's in USM. So this is master's in surgery, I presume, as he was a registrar in USM since 2002 and has received awards for his high quality teaching and frequent examiner in the teaching career. Currently, Associate Prof. Dr. Pei is a member of the Malaysian Medical Association and has a number of publications in the local and international journals, attended a number of conferences in Malaysia and abroad, including that of the National Annual Scientific Meeting, College of Surgeons, Academy of Medicine. We will then move to the second speaker today. Again, I apologize for the difficulty in getting the screen shared. Second speaker today is Professor Dato Dr. Haji Abdul Razak bin Abdul Muttalib, who earned his MBBS from the University of Malaya in 1982 and had postgraduate training in University Kebangsaan Malaysia, received in Masters in Internal Medicine, where he received his Masters in Internal Medicine. And in 1995, he moved to the United Kingdom to commence respiratory training in the Royal Brompton Hospital in London. And in the same year, earned an MSc in respiratory medicine from the University of London. He has served as consultant physician, chest physician in the Kuala Terengganu Hospital, Penang Hospital, and was director of the Respiratory Institute, Kuala Lumpur, and head of respiratory services in Malaysia. He moved to Masa after retirement from the Ministry of Health in October 2017 as Professor of Medicine, and he has presented more than 100 papers, research papers in peer-reviewed journals, and involved in numerous respiratory disease guidelines like COPD, asthma, TB, and multi-drug resistant tuberculosis. I now call upon Dato to give his talk.
Thank you, Dr. Segren, for the nice, kind words. Can you all hear me?
Yes.
Dr. Segren, I can't see my slides, so I got to press share, is it?
Yes, Dato. You need to share the. You need to press the button share.
Okay. So the thing is, my slides already open just now. I think you already put on in your background, you know.
Yes. Okay.
So you got to open up for me, I think. Or let me just see. Can you see now? Dr. Kokomi, can you see my slides? Hi. Can I hear anyone from there? Dr. Kokomin, Dr. Segren? Hello? Hi.
You can say something. We are waiting for.
Please hold on. We are waiting for the slides to be uploaded.
Ada kau come in. Hi. I can't see. I can't hear. I can't hear you also. I cannot hear you. So how? I already opened the link already. I already opened the link. Okay. So I can't hear anybody. Can you hear me? Okay, then I can send the slides. I can see the slides. I already pressed share just now. I'm going to stop share and then I'll go back again. Okay. Hold on. I'm just going to share my slides again. Okay, bye. Sure. Thanks. Bye. Can you all hear me? I'm sorry. Hello. I really hope you can hear my voice. I'm sorry about all this confusion. I'm going to talk about long COVID syndrome this afternoon. I think you all know about the COVID issues that have been here for the past 2 years right now. And we've been seeing lots of problems in patients having COVID over the past 2 years. I'm going to share some of these studies and also some of these issues in these patients. This is my topic for today's afternoon. Okay, locally, this is actually the paper actually presented by Dr. Suresh and also from people from all over Malaysia, and they found that out of this 5,000 cases in Malaysia, 50% is stage 1, 30% is stage 2, and only about 40% is stage 3, 4, and 5. Okay, so only about 8% total were in a very severe kind of stage for this COVID in Malaysia, all over Malaysia. And who are the people on high risk to get COVID-19 here? The main thing is older people. Those more than 70 years plus, they got very bad COVID in their symptoms. And what about the risk factor for severe COVID-19? Again, the other thing is anyone more than 50 years of age, they got comorbidities, they got more chance to get very bad COVID and also more complication this COVID patient. How do they classify this one? Okay, you can classify this COVID by a few things. Okay, the first thing is that by time base. By time base, they can classify them. And the other thing is by severity base, and third thing is by organ base. Time base means either it's acute COVID or it's long COVID. So that's very easy. It's either acute or long COVID. Severity basis, again, I think you all know it's either mild, moderate, or severe. The mild is anyone who got very mild symptoms and reversible. That's very important. And moderate is when the patient got something not so bad as severe, but in between, and they can be treated and they can be reversible. The worst thing is those having the severe organ dysfunction. These are people actually can develop lots of complications. They may get organ damage which is irreversible, and they may get other complications which I'll go through later. Organ base is very interesting. They can, again, due to COVID-19, the organ, they put them into either cardiorespiratory organ or they go to extrarespiratory organ over there. So cardiorespiratory organ, you can say respiratory is the main thing very important in COVID. Okay, that's the biggest thing actually is can cause the patient lots of problems. They get lung fibrosis, lung function goes down, they get dyspnea, can go on for months and for years. And cardiac function again will be affected, the diastolic dysfunction, also mechanical inflammation by this virus. And again, other organs will be hematology, neurological, renal, and systemic kind of disease. So they can affect every organ in your body with this COVID-19. Okay, it can be either acute complication, they can also be chronic complications. What did Malaysia says about this thing? Malaysia also got their own sort of definition for long COVID syndrome. They go by the time frame. Acute COVID is anyone within the first 4 weeks of infection. They call them acute COVID. Ongoing symptomatic COVID-19 is again 4 to 12 weeks. The one that's called long COVID in Malaysian sort of definition is those who actually have symptoms which is lasting for more than 12 weeks. And they have to exclude other diagnoses for these patients. So any patient got COVID more than 12 weeks ago and no other medical problems, but just COVID causing all the symptoms, then you can tell them they got post-COVID or long COVID syndrome. These are just an example. This is from Malaysia again. Again, for the Malaysian sort of a first edition for this long COVID kind of symptom in Malaysia. After 4 weeks, what did they find most? They find most patients are fatigued. They got exertional dyspnea and they also got insomnia. Most of these patients after 4 weeks. And after 12 weeks, you find them, they still got fatigue again. And they are still breathless and they can't sleep and they can cough and they got anxiety and they got depression. So these are all things you can see in patients who got long COVID after 12 weeks of infection by this COVID virus. I just want to talk about long COVID in lungs because I'm a chest physician. This is a nice study done by Combine and also by Barrett, published in Lancet Respiratory. Very nice graph here. Anyone got infection by COVID, 95% of them have got mild symptoms. So it just comes and goes, just like a viral fever, very good. But 5% will have severe or critical symptoms. These are the people actually we're sorry for about. And all these 5%, 30% will recover fully, and 20% will die. And of the 30% actually will end up with lung fibrosis. So this is one virus which actually is really troubling lots of people with these complications. We do not see this in influenza. We don't see in any other viruses, no? But COVID virus infection in the lungs, about 30% of these 5% of patients will develop lung fibrosis, which is irreversible, very frightening. This is what they find. They find that the pneumonia in COVID-19 is a pre-fibrotic condition. So anyone who got pneumonia because of COVID-19, they can actually get bad fibrosis if they end up in ICU. So there's a risk factor over there. And again, they find that lung function goes down. The DLCO is the diffuse capacity for the carbon monoxide goes down. Total lung capacity goes down. And the forced vital capacity also goes down in these patients in 6 months to 12 months. And who are the people who get all these things in the fibrosis? Male, more chances to get fibrosis. Older people, increased BMI, and anyone who got severe COVID-19, they got more chance to get lung fibrosis compared to mild to moderate COVID-19 lung infections. And they also end up with bronchiectasis, all these patients. So in that study, they found that COVID-19 is a severe pro-fibrotic condition, and the fibrosis can persist for many, many years or even for months, okay? Up till now, we can tell for 2 years so far, okay? It may go on for a longer period, if you ask me. This is a study done by February and his colleague. They did a systemic review and a meta-analysis of lots of infection of the lungs. They took the influenza viruses, they took the bird flu viruses, they put the SARS virus, they even took the MERS-CoV virus, and now COVID-19. And they find that in all these viruses, they actually do have some lung pathology. Okay, they find out that the lungs can be damaged and they can actually affect the lung function over the next few weeks or few months after the pneumonitis. Local studies, okay, just want to share some local studies. I've got a opportunity to be one of the investigators for this respiratory function survivors for long COVID or COVID-19. Is a cross-sectional study, and this is just the prelim results. We are still going on with the study, so we can't publish completely yet. So UNIMAS, MASA, and UITM to fund this study. We got about 324 patients over the past 3 months right now. You look at these spirometry findings. 30% actually got abnormal spirometry, and this is 1/3 of the patient, and this frightening, 1/3 of the patients. And what did they find actually? So these are patients who got normal spirometry, and these are patients who got abnormal spirometry. So 95 patients out of 324. And they are usually slightly older and a bit more in the male and more in the Malays, probably because the population in Malaysia is more Malaysians. But again, I will still say it's slightly more in the Malays, followed by the Chinese and the Indians. And again, the abnormal thing you can find here is that the category 4 and 5, those in the COVID-19 category 4 and 5, they got more chance to get abnormal spirometry up to 50% and 46% compared to category 3. That's one. And the other thing is, these patients followed up for 3 months, and that's where they found this abnormal spirometry. And again, MMRC is a breathlessness score for the lung function. So 2 to 4 means very bad respiratory function. So about 30% actually end up with very bad respiratory function. They are very breathless, even at rest, they can't walk at all. Category 0 to 1 MMRC, actually, people can actually walk, but not so well like a normal person. And again, the 6-minute walking test, they found that it's abnormal in half the patients. So those who got lung fibrosis with abnormal spirometry, they find that the patient cannot walk like any person for the 6-minute walking test. So you can see that physiologically, the lung function actually goes on a lot with the damaged lung and due to the fibrosis. And again, what did they find here? They find that the FE1 FEC ratio is higher. When it's higher than 70%, it is a restrictive lung disease. And basically because of lung fibrosis. Okay. So all those people that got abnormal spirometry actually end up with lung fibrosis, even in Malaysian context, very easily. Now, study done by the same group, by UITM, also by UNIMAS. They did the imaging studies for COVID-19 patients. It's a 3-month follow-up study here, and in COVID patients. I'm quite happy to say that one of our medical students will be doing the same study, similar study on X-ray severity in COVID-19 patients with comorbidity. We just got a prelim sort of agreement with the Singapore Hospital. Inshallah, we getting data from the patients soon and publish hopefully by end of the year. This will be Masa student plus me as a supervisor. So what did they find the X-ray again? Out of 175 patients with X-ray available, they find about 1/3 again abnormal. And again, what did they find the X-ray? They found consolidation, reticulation, which is commonly seen in fibrosis, and ground glass opacity. Ground glass opacity basically means the lungs are inflamed. So whenever the inflammation in the lung, the early part of inflammation, that's where they get the GGO. They call them GGO. GGO stands for ground glass opacity. And this is what it looks like. So black thing is normal lungs, and this is what they call a ground glass opacity here. Okay. And then when it becomes worse, it can affect both the lungs. The opacity here is called ground glass, and this is called ground glass opacity. So this is what you look for in the X-ray. You can see the same thing also in CT scan. When some of them got CT scan finding, about 11% actually were abnormal. 90% were normal. And again, they find that the most common thing is ground glass opacity. Okay. And again, like I mentioned just now, many of them can actually end up with fibrosis. These are all fibrosis at the peripheral level here, the pleural base they call. Fibrosis, bronchiectasis, and everything. So these are all damage done by the GGO and also by the pneumonia due to COVID-19. So they concluded in this study that most patients actually were normal X-ray, but those who got abnormal X-ray actually got ground glass opacities, and they all end up with fibrosis-like changes on the CT scan. So our finding compared to other studies done in Italy and also in Europe, it shows that most patients with COVID-19 bad lungs do actually end up with lung fibrosis. Okay. So how do you manage? Okay, Malaysia came out with a nice guideline for post-COVID management. And this is published just last year, August. Okay, and it's available online for those who are interested. Once again, because I'm a chest physician, I'm going to talk only about lung sort of involvement. So, like I say, long COVID can affect anything in your body: your ear, nose, and throat, your respiratory, your CVS, your gastrointestinal, and everything under the sun. Okay. I see got patients who come and tell they feel so depressed, they can't sleep very well, they can't smile very well, they feel dizzy, they can't think well. So it's going on for months, and you feel sorry for them because their life is really not like before. So they can't do anything like before. So they actually got limited sort of activities compared to before. So for respiratory, again, what they say that any patient with respiratory symptoms, they can either be new or can be old. Then you can look at respiratory rate, do the oximeter, do the 6-minute walking test, and do a chest X-ray, okay, and do a spirometry there. And then again, once you find the abnormal anything here, refer them to either family medicine specialist or the chest physician. Then they can do further tests by doing a spirometry or differential capacity test by the DLCO. Send them for HRCT or CTPA, look for any embolism for this patient. If there's anything abnormal here, they will probably refer to a chest physician. Okay. Again, that's when we refer the patient for rehabilitation. So we can't do much for these patients when they got this lung fibrosis because there's no treatment at the moment which is good to reverse the lung fibrosis. So what they always say is that the best thing is let them go for good exercise and rehabilitations. And with that, we hope that lung function actually improve a bit compared to before, and they can feel a bit better and stronger with the improvement lung fibrosis and lung function over there. This again is just to show the flow chart for a patient actually who come with all these COVID symptoms. And this is in stage 3 patients. They got the algorithm over there, and this is for the stage 4 and 5 patients. So it is all in the guideline. You can see in the long COVID syndrome guideline in Malaysia, and I will not go through these things. So my last slide is it's unknown how it be affecting people over time. Okay, as far as we know, we only got 2 years experience with COVID, and we know these 2 years the damage done to the whole part of the body is really very, very bad, especially to the lungs. And like I say, it's mostly irreversible. And the health concerned people who had COVID should be monitored closely because, like I say again, it can affect every organ. They may come with very big symptom which we never know like is due to COVID. So it's good that we have an open mind and open eyes and open ears to see what the patients say about their complaints. It can be true, we do not know. Okay? Whatever thing they say may be true. There's no way you can actually prove them right or wrong. So we just got to take their word in the complaints and then guide them in the proper way to assess their abnormality. And most people like COVID-19 recover quickly, yes, but then some people who are unlucky, they can actually have long-lasting problems. We can go on for months and for years. And this is the last important thing. Okay, there are a lot of things going on about anti-vaxxers and anti-vaccine, all those things. Whatever things said and done, the most important thing is wear your mask. Physical distancing is very important. Avoid crowds if possible. Get a vaccine. We don't know how good or how bad the vaccination is right now, but the thing is something better than nothing. Okay, to prevent something bad to happen to you or your family. And keep your hands clean. Okay. So that's my last slide. Thank you very much and stay safe and take care. Assalamu alaikum to all of you and take care. I'm really sorry. I don't know what I'm talking to the wall or talking to you all. Okay. I'm really sorry. There's something wrong with the system and I think we are doing it for the first time. Hi. Hello.
Can you hear me, Dato?
I can hear now. Did you hear what I said now?
Yes.
Can you
Loud
see
and
my
clear.
slides? You can see the slides?
Slides, no.
Oh, that's very sad. That's very sad. Okay.
We are
That's
having
very sad.
technical problems
Yeah. If you want, I can share my slides to Masai. No, I already given the
Sure,
slides
thank
to
you.
Dr. Anko Komin, and Dr. Anko Komin can actually put the slides maybe in the LMS portal. They can actually have a look at the slides.
Doctor, the question just now,
Yes.
the other damages to the body beside the lungs.
Yes.
Can you elaborate on that?
Yeah, I already showed the slide just now. The thing is that they can affect every part of the body. I don't know if you can see this slide. The ENT, they can get tinnitus, earache, sore throat, and loss of taste and loss of smell. And for cardiovascular, I already told you they can get all these myocarditis and ischemic heart disease. For GI, they can get abdominal pain, nausea, diarrhea, anorexia, decreased appetite. And then again, for neurological, it's very, very sad. They get cognitive impairment, They can't actually think very well. They lose concentration. The memory is very, very poor. They may end up with lots of funny headache symptoms. They can't sleep very well. They get neuropathy. They get dizziness and also delirium sometimes. So again, neurological can be very bad for some patients. I got some of my relatives who got COVID-19. They come and ask me with lots of these complaints. I just tell them I can't do much for them. It's very sad, really sad. And psychiatry, why they can go to depression and anxiety. And musculoskeletal, again, I think you all know they can get severe joint pain and muscle pain. And some people eventually can end up with rash. Okay, so if you ask me, it affects heat to the food. Okay, so once again, I'm telling you, any patient with post-COVID, they come tell you about any funny symptoms. I think we should take it that they're saying the truth. Okay, because we don't know. Okay, we don't know. What they say is only they feel the trouble in their body due to post-COVID. So we just got to listen to them and then counsel them and then give them some advice if possible. Looks like that. Okay. Hi. Any other questions? Hello. Hi.